Hello, my name is Alina Denham. I'm a PhD candidate in Health Services Research and Policy at the University of Rochester, and I study healthcare use, particularly ED use, and health of vulnerable populations in the context of policy. Today, I present some of the findings from my dissertation. Non-emergent ED visit rate in Medicaid is exceptionally high. In 2009, this rate among adults was 515 visits per 1,000 enrollees, significantly higher than all other insurance groups. Expansion of coverage under the ACA intended a specific effect on ED use, a reduction in visits. Implicit in this reasoning is that as people would gain access to office-based care, they would rely less on EDs, or in other words, that people would substitute primary care for ED care. And yet, after Medicaid expansion, ED visit rates in Medicaid increased. A few explanations could explain this unexpected phenomenon. And if we turn to economics, both substitution and complementarity between ED care and primary care could explain the increase in ED visits. So I ask, which is it, substitution or complementarity? We care about this for several reasons that include policy and practical considerations of how to best provide healthcare while being cognizant of both financial implications and disparities in health. Theoretically, ED visits can increase after an insurance expansion with either substitution or complementarity with primary care. Practically, policy solutions to high ED use should be drastically different depending on whether ED is used as a substitute or a complement to primary care. Empirically, only one paper tests substitution versus complementarity, but it doesn't account for barriers in primary care. I provide definitions of substitution and complementarity here. An example of substitution is a brand name medicine and a generic medicine. An example of complementarity is a doctor visit and a blood test. For the ED primary care dyad, referrals from the primary care provider to the ED would normally fit here. So in order to test substitution versus complementarity empirically, we build on consumer choice theory from economics. I won't go into derivation today, but the test can be performed by looking at the ED use as a function of primary care supply. In both cases, it is a two-spline function, and the difference between the two is in the slope of the left spline. And with the following estimating equation using nonlinear least squares approach, we can test substitution versus complementarity, which will be indicated by the sign of coefficient beta. In this research, I focus on New York State, which has unique provider data files, Medicaid managed care reports, and rich ED data, allowing for a unique data linkage. I used data for 13 months in 2014-2015, data structured at county year-month level with 793 observations. I looked at ED visits for 100% primary care treatable conditions based on NYU algorithm. For the provider rate, I included primary care providers that report accepting Medicaid patients. Because enrollment report numbers, my denominator for the rates, were only available for children and non-elderly adults in aggregate, this is our study population. The best specification was achieved with county fixed effects and 3 covariates listed here. Although availability of urgent clinics might be an important confounder, it didn't vary much over time in our data, and so it's subsumed in the county fixed effects. So what do we find? In the state overall, there is evidence of substitution across all hours. In the subgroup analysis, I found that the relationship is primarily substitution, but there is strong evidence for complementarity during nights and weekends in highly urban counties. In the last 2 columns here, you see estimates for poorer versus wealthier counties. Overall, substitution dominates, but the 2 types of care are complements in highly urban and poor areas during nights and weekends. Now, in analysis by provider type, I'm not testing substitution versus complementarity per se, so I report point estimates. We see that with higher physician supply, ED use decreases during the day and increases in highly urban and wealthier counties during nights and weekends. Interestingly, our results for advanced practice practitioners are exactly the opposite, which can have important implications for how healthcare is provided. Now, briefly, results from the pre-expansion period. Here we find strong evidence of substitution across counties and time of ED visits, and no evidence of complementarity in any subgroup. So complementarity relationship emerges after 2014. However, the mechanism of this is unclear. We cannot tease out whether this is due to the expansion of eligibility or due to the increases in Medicaid provider reimbursements, which also took place in 2014. There are several limitations that I would like to acknowledge, but in the interest of time, I'll just provide the slide here. What I want you to take away from this presentation is this. ED visits in primary care can be substitutes or complements depending on time of day, urban versus rural area, and poverty level. And primary care provider, physician versus APP, matters in affecting ED use. There are several policy relevant benefits from illuminating this relationship. And again, I'll just leave the slide here. The research I presented today is part of my dissertation, and I would like to acknowledge my dissertation committee. Thank you for listening in, and if you have any questions or comments, here is my contact information.